Hello friends, today we are going to discuss a bit about how to program cycles in IVF program. I'm sure all of you need to do that for two reasons. One is of course you don't want the egg retrieval on a particular date because of unavailability of yourself or the embryology staff. And the second is of course to get a very uniform cohort of follicles to give you the best crop of oocytes and therefore top quality embryos. Now the classic way of programming which all of us have been used to for so many years has been the use of the birth control pills, but there is a lot of recent data to show that this may not be the ideal way to go. So we know that if you give birth control pills, you are likely to have a prolonged duration of stimulation. This is most likely because of excessive suppression of LH. Also, because of this, you will have excessive consumption of gonadotropins, and at the end of it, you may not get the optimal number of oocytes, and therefore your ongoing pregnancy rates are likely to be lower. Also, many of you might have noticed that in egg donors, who very frequently are usually put on contraceptive pills by the agencies who recruit them, very often you find that when you finally give them an agonist trigger because you don't want to give the HCG trigger to avoid OHSS, you don't get the ideal number of metaphase 2 oocytes. There's a recent study which clearly shows that the higher the extent of LH suppression at the beginning of stimulation, the higher is the percentage of suboptimal response. And if your LH is very low, almost 35% of cycles might have a suboptimal response with subsequent gonadotropin and agonist trigger stimulation. So what are the alternatives available to us? The next best is of course the use of estradiol valerate, which is very simple to use. You just give 2 milligrams BID from day 25 of a 28-day cycle. You then ask the patient to report on day 2 or day 3 of her menstruation. The beauty of this is that it does not interrupt her normal menstrual cycle. So she will get her menses at the regular time. She comes in on day 2 or day 3, but it happens to be a Monday and you don't want to begin stimulation because egg retrieval would be on the following weekend. So all you need to do is you can push the stimulation by as much as 1 week. So you can begin stimulation on day 9 of her cycle, just making sure that you continue estradiol valerate until a day before you begin the FSH stimulation. So it's very easy to do. The only thing is the bleeding will stop, a triple line endometrium will form, but there will be no recruitment of a dominant follicle. And that is what you want, that you do not want a dominant follicle when you begin ovarian stimulation. So you can postpone from day 2 to day 9 simply by continuing the estradiol valerate. There is a very interesting recent study which shows that you can keep giving the estradiol valerate even after you begin FSH stimulation and go on until the day of HCG, and this is actually supposed to give much better pregnancy rates than if you stop it when you begin the FSH stimulation. The beauty of this estradiol valerate program is that even if the patient is inadvertently pregnant in that cycle, this will not affect her pregnancy. Estradiol would not have any adverse effects on the offspring, and you can just withdraw it or stop it once you know that the patient is inadvertently pregnant. A recent and a very novel way of programming cycles is with the use of our classical norethisterone, which we've always been using for postponing menstruations during, say, a puja or a marriage ceremony. You can now use this very well for programming IVF cycles as well. So all you need to do is, as per the latest released Fisher protocol in 2019, you give norethisterone from day 20 of a menstrual cycle, obviously, which means it has to be started post-ovulatory. You also need to be sure that the patient has not tried for a natural pregnancy in that month, because we don't want her to inadvertently take norethisterone during an early stage of pregnancy. So you begin norethisterone from day 20 in a BD dosage. You can give it for a minimum of 7 to a maximum of 14 days. And in between the 7th and the 14th day, you can stop the norethisterone on any Sunday. If you do this, she will menstruate on the following Thursday. Friday would be her day 2, and you then begin your FSH stimulation for the IVF cycle. Now this works beautifully. So what we do is we generally try to stop it on a Sunday. For you it may be different. You may want to stop it on a Wednesday or a Friday. Basically the principle is 7th to 14th, minimum 7 days, maximum 14 days. The maximum could be extended to 20 days as well if you are going off on a long vacation and still you want to program your cycle. Now this is of course as per the publications which are available to us and common practice in most international centers, but I have found one more novel way of using norethisterone. Suppose a patient turns up to you on day 2 of her menstruation, and this happens to be a Monday and you don't want to begin stimulation on that day. All you need to do is give a norethisterone for a minimum of 5 days. You can extend it to 7, 8, 9, 10 days as well, and then begin stimulation 5 days after the last norethisterone tablet. So for example, she came to you on a Monday. We would give norethisterone twice a day, say until Sunday. That is a full 7 days. Again, she will bleed within 10 days of her initial menstruation on the following Thursday. You begin stimulation on Friday and you salvage the cycle without having to waste an entire month. So as of today, we have these beautiful methods of programming available to us now, especially the use of estradiol valerate, as I told you, where you can push by a week, or the use of norethistérone by the Fisher protocol, starting on day 20, minimum 7, maximum 14 days, or in an emergency, even starting it on day 2, just giving it for minimum 5 days, maximum 10 to 15 days, so as to extend your cycle and not waste an entire month for the patient. Thank you.